Hey everybody, and welcome back to another edition of the Physiotutors podcast. Today we have with us Dr. Jorge Chahla. Dr. Chahla is the head physician for sports teams like the Chicago Bulls, the Chicago White Sox, and Chicago Fire. So you got the NBA there, MLB, and the MLS over in the US, if you guys hadn't picked up on that. He's also the head of the biomechanical research over at Rush Orthopedics Hospital, and also the director with regards to fellowship training and whatnot as well, if I'm not mistaken. But enough from myself. You're not here for me. We're here to hear from the man himself. Dr. Chahla, would you mind giving us maybe a 1-2 minute introduction to who you are, what you're about, and then we'll just dive on in.
Thank you very much for having me, Physiotutors. It's a great honor for me to be here with you guys and share some time and hopefully learn from each other. I'm originally from Argentina. I did my residency there, my PhD over there in cartilage disease. And then I moved here to the States, did a couple of fellowships. People that are not as fast need to do multiple fellowships to be able to learn at the end. So that's what I did. I started my training in Vail, Colorado, at the Stedman Clinic, and continued in LA at the Colonel Job Institute, Cedars-Sinai. And then I came here to Rush University, where I've been an attending here, working on complex knee, complex hip, all, preservation stuff, as well as some shoulder pathology. And I serve as the director of the International Fellowship, as well as the Biomechanics Department here at Rush. We are a group of 10 people in the sports medicine division, and we split the coverage of the Bulls, the Sox, and the Fire, which are the teams that Chicago has. And it's been very exciting for me to treat these patients and also the weekend warriors that we see on a daily basis in clinic.
Nice. Perfect. I mean, it must give you a nice contrast to the guys that you see in the top end of sport. And then, like you say, to the weekend warriors, just to almost keep your feet on the ground with expectations of just how the surgeries and whatnot can potentially go. So let's start there. Whether it's a weekend warrior or whether it's someone who's competing at the apex of sport, when you get them into clinic, let's start with the knee nice and easy. What is it that goes into your decision-making process with someone as to whether or not to operate or whether or not to do something like imaging? I know here in the Netherlands, at least from the physiotherapy side of things, we hesitate to jump into imaging too quickly. I know in the States, you guys have it a little bit different with the healthcare system over there, and it's a bit more litigious, if we put it that way. So for you guys, I suppose there's probably more T's to cross and I's to dot. But what goes into your decision-making process over there?
That is a really good question. And as you said before, very correctly, we are very aware of the legal stuff. So we have no hesitations on getting advanced imaging, just to make sure there's nothing else going on. From a healthcare standpoint, it makes a lot of sense when you have certain clinical parameters not to obtain any further imaging, because most of the times, over 90-95%, it's going to be what your clinical judgment tells you that it is. But there will be that 5-7% that it's not, that you can actually find on further imaging. So that's why, in an effort to protect ourselves, as well as patients are becoming more and more demanding in regards to what is the actual diagnosis. You can't just say it's an arthritic flare-up, but is this a meniscus root tear? Is this a cartilage injury? They want to know exactly what's going on. And, we're very aggressive at getting further imaging or advanced imaging so that we can know exactly what's going on so that we can treat it properly. Now, what goes into my mind is I'm a very minimalistic surgeon, if that's a good way to put it. What is the least that I can do to get that patient better? Surgery is not ever 100%. It's not something that I can assure somebody, if I do surgery, you're going to be 100% better. I can assure you that this will be the case. And therefore, I'm very minimalistic in my approach, which means I try to keep them off from surgery as much as I can. And we try conservative treatments. I always explain what are the stages or steps that we need to go through before we get to surgery. And that means usually a conservative period or a trial of physical therapy that includes at a very minimum of 6 weeks, regardless of what they have. The only case in which I would jump in before is, let's say it's a bucket handle injury, a multi-ligament injury, or something in those lines that will basically not have a great outcome if we keep that knee locked in flexion or something of that nature. But besides that, most people will benefit from physical therapy and potentially injections or just time. Voltaire has a great saying, which is the art of medicine consists of having or basically be a companion to the patient while nature heals the disease. And most of the times being too aggressive with surgery can get you in trouble. And being part of that decision making with the patient, telling them, my job is not to operate on you, my job is to inform you so you can make the right decision, and help them or guide them through the decision making, and saying, we're going to try physical therapy now. Most people will improve with that. If you don't improve with that, we can try injections plus more physical therapy. If at the end of all this process you have still not improved as much as you wanted to, or your function is not to the level that you wanted to, then surgery becomes an option. And in that case, you have bought into that idea with the patient because they know that you're not just selling this operation, and you're basically trying to help them. And again, most of the times you won't need to get to surgery.
I like the way that you put it there as well, the fact that you're there to advise the patient so that they can make the right decision for their specific situation. It makes me think of a patient that I've had quite recently, actually, who a shoulder slap lesion, and we went through a good solid 6 to 8 weeks of rehab, slowly seeing some improvements and whatnot. But he wanted to get further imaging done. It's up to the patient. I've got nothing against it. For me, I knew what it was from my diagnosis, and my plan of care wasn't going to change from the results of the imaging. He'd already had the x-rays done after the shoulder dislocation, so we knew there wasn't anything going on there anyway. And as soon as he saw the surgeon, as soon as he came out, rather, I got a teary phone call from the fella just saying, listen, the surgeon said it's like over for me. I need to go into surgery straight away, blah, blah, blah. And I was like, this doesn't sound right. Tell me what you said, what imaging he saw, and what his decision-making process was, how he talked you through everything. And the way that it came off for the patient was, this guy's just trying to get him into surgery. The way that it sounded to me was, he just wants you in that operating theatre today. Like, he wants you in there an hour ago. Sent him through to another surgeon, and they sat down, had a proper conversation with him, gave him all the different options, the pros, the cons. Like you just said there as well, there's no guarantee that you're going to return to 100% function the same as you were pre-injury. And I hope that's improving with regards to both surgeons, physios, everybody in the healthcare, really talking to their people more, to their patients more, and working with them. But it's refreshing to hear that from someone who's in such a prominent position as yourself as well. Because I think same with physio, sometimes we're too quick to just jump in and shove our oar in just to do what we do best, without giving further regards to how the patient feels. So you mentioned sort of the bucket handle tears and multi-ligament injuries, maybe an unhappy triad or something. But are there situations where you might strongly advise a patient to operate or to go for the biologics side of things with an injection? And what would those instances be? Any joint, doesn't have to be the knee.
So there's two types of situations. One is when there's risk of a limb, which can happen on a multi-ligament injury where there's significant, instability with a vascular injury or something of that nature that needs to be repaired right away. That is, the only emergency besides, a compartment syndrome or something outside the sports medicine world, but that is the only emergency for surgery. Now, multi-ligament reconstruction, we did a Delphi consensus statement looking at 35 surgeons around the world, and everybody agreed that when you do surgery within the first 6 weeks, that's when you get the best results. It's not an emergency, but it's an urgency. You have to do it relatively soon. That being said, you should never operate on a patient that doesn't have full range of motion. And for these people, this is very common. They have, right? They're guarded, they have 10, 15 degrees of lack of extension. those people will never do well after surgery if you don't recover that extension. So prehab for those cases is critical. If you don't prehab those patients, outcomes would be extremely bad. We know that with multi-ligament reconstructions, you want to be as anatomic as possible so that the physio can move them from day one. And that was the main issue why, previously a multi-ligament reconstruction was not a great surgery, because they would get stiff. They'll put them in a cast for 4 to 6 weeks, which is, the worst thing you can do at this point, because they need to move. So if you do an anatomic reconstructions, you can allow range of motion from 0 to 90 from day one. And, that allows those people to get back to their normal range of motion pretty quickly. But again, if they didn't have that before, that's a big issue. And the second thing is when they have a mechanical log or a mechanical issue, such as having, a portion of a meniscus in the notch. So they won't be able to move regardless of what we do. There's some techniques that have been described to reduce the meniscus, but they're unreliable. And it's unreliable that the meniscus will stay there. So for those cases, until there's further, literature suggesting that conservative treatment can be a good option for those people that have a displaced back and handle tear, we recommend a surgery which is not emergent, but needs to be done relatively quickly to improve the chances of a biological healing. So from a biological perspective, we never use this in acute setting or as a first line of treatment. We usually try other conservative measures before. And in the event that they don't work, then we go to the more, advanced or invasive things such as platelet-rich plasma or gel injections or even stem cells. For the weekend warrior, they have an out-of-pocket expense, so it's not something that we recommend as a first line of treatment. And that's something that, depending on the chronicity of the symptoms on a professional athlete, it can be done, but usually we don't do that as a first line of treatment.
Okay. We'll come back to the athlete side of it in a second, but I just want to pick up on what you were talking about there with meniscus injuries. You mentioned there that the body of research for bucket handles is still a little bit inconclusive with regards to pure conservative care. I personally have had a bucket handle and I have had really good outcomes post-surgery. I tried rehab on 3 separate occasions and still ended up going for the surgery. I've had multiple patients who've also had the same thing. And for myself, the advice that I gave them alongside what they'd received from the orthopedic surgeon, sometimes they'd see me first, sometimes they'd see the surgeon first, was always a case of, if you have this continual locking, if it happens more often and it's affecting your daily life, then it's something that, if I was in your shoes personally, I would then consider. If you're unable to do the sport that you want to do, if you're unable to, walk the dog or something due to fear of that locking coming up. One of the things that people often say is that, again, the surgery isn't a guarantee for those symptoms to go away. There are still people that have instability. There are still people that have the locking. Where do you go with that side of it if a patient does continue to come back with these issues? Because that's also something that we see in the research with both sides of the coin, conservative and operated. Why do you think that is? So
whenever you do surgery, there's a percentage of surgeries that won't go the way that you want them to go. It's a minority, right? It's a 3 to 4% that sometimes there's things that happen, not necessarily in surgery, but after, that depend on a lot of factors. One is the alignment of the patient, the weight of the patient, where the tear happened, the chronicity of the tear. If the patient actually did not put weight on it from the get-go, and so forth. So there's so many variables that will affect the outcome of that surgery that it's impossible to predict or to basically report for all comers. It needs to be tailored to each specific case. Sometimes when you do a back and handle tear, most people feel incredibly well afterwards, because you put the meniscus back, you suture back, they don't feel that sensation in the inside of their knees, and they just feel good to go. That being said, the problem is that some people will push it too much, and sometimes one is they will load the joint before it's ready for prime time, and it's not healed, and the sutures will not last forever. They need the biological healing of the meniscus to be able to function very well. and they will re-rupture the tear. That's one option. The second option is sometimes there's clicking that might be coming from two places. One is from the front of the knee, which is very common when they have still not a strong VMO, so they have patellofemoral biomechanical issues. And the second thing is when scar tissue forms, that can cause clicking as well on both sides of the knee. So, those two things are the most common things that we see, being the patellofemoral issue, the main one that we discuss with patients. I usually tell them, when they start telling me about clicking, I say, is that in the front of the knee, mostly when you go up and down stairs and so forth? When they say yes, they feel relieved because that they're not the only ones that have felt that. But most of the times that goes away, as soon as you build up your VMO.
Perfect. And then what about instability complaints, either pre or post-op? How's your experience there with your patients?
So instability is not as bad when you have a meniscus tear than when you have a ligamentous tear. That being said, from our lab, we have found that if you tear the posterior horn of the medial meniscus, you're going to have increased anterior translation of the tibia. And if you do the same on the lateral meniscus, you're going to have increased rotational components to the instability. So, that allows you to suspect if you have anteromedial, anterolateral instability in the setting of normal ligamentous anatomy, you should suspect that there might be going on with the posterior horn or the roots of the medial lateral side, respectively.
What about making the decision of going to the injection side of things? Does that have anything to do with the sport that they're doing, or if you're working with the athlete in the timing of the season or something? If it's coming up to, if we're coming up to the final 6 games or whatever, is that a point of time where you're then going to maybe make the decision to forego surgery for now, get them to the end of the season, and then push forward? Or?
So that is a great question, and it's mainly dependent on who is the patient, right? Like if you have a professional athlete that needs to get through the season, again, we think about the same things. What is the least that I can do to get him better? What can I do to make him, complete the season? What will get him another contract? Those are all the things that are in our brains when we treat one of these professional athletes. We want to be the less disruptive as we can to keep them going. So if a PRP injection to a horizontal cleavage tear of a meniscus might get them better, that's what we do. Now, for a weekend warrior, there might be more of a cost issue to pay for PRP or the gel or come to the office as often to get 3 series of injections. We try physical therapy first because that might be their best bet, and most of the times that's the only thing that they need. Now, if they have recurrent symptoms, they have still inflammatory symptoms, then we offer these biological injections, and we have a booklet prepared that basically explains what a cortisone injection is, what a hyaluronic acid injection is, difference between PRP and BMAC, and so forth. And patients appreciate that because you make them part of the decision making, in regards to the treatment, so they feel empowered that you're actually giving them the information for them to make a decision.
Okay, so it really comes down to that there's no hard and fast rule. It comes down to the individual and the individual's requirements then.
That is correct.
Maybe for the listeners, if you could briefly just outline the differences between when you'd use something like a corticosteroid injection, when you'd use something like PRP, and what are the reasonings behind the different types?
So we just completed a network meta-analysis, which allows you to compare all these different treatment options to each other, which is a great way of actually seeing which one will produce a minimally clinically significant difference. Because a lot of the times papers will report what is statistically different, but a VAS score difference of 0.5 points may not be clinically different, right? It might be statistically different, but not clinically different. So that's what we are trying to figure out now. What are the things that will actually guide you to a clinically meaningful difference in that patient, something that the patient can perceive as, meaningful to them. Cortisone is a very, very powerful and effective treatment. The problem is that it's not durable. The main duration of cortisone, it's said to be around 2 to 3 weeks. So it's not a whole lot, which is great for people that have an arthritic flare-up. So if you have an arthritic flare-up, you put them on a cortisone injection, that will calm them down and make them go to that baseline that they were before, that was their comfort zone. It might not be a normal baseline, but it's the baseline that they were used to being at. And that makes them feel better. Now, if you're treating something that is more chronic in nature and you want to keep a baseline level of anti-inflammation or keep the homeostasis of the knee, that's where, and if you failed, for example, a cortisone injection, or let's say you actually improved, but it was not durable in time, that's where the other options become an option. And, a gel injection has probably 17, 18 randomized clinical trials, and not even randomized clinical trials, meta-analysis showing that when you use a high, molecular weight injection, multiple injections, it can be pretty effective. We just completed the clinical practice guidelines for the American Academy of Orthopedic Surgeons, and what they have found was that the number needed to treat for gel injections was about 17 people. So you need to treat 17 people to have one minimally clinical difference achieved, which means that, it is effective, but not as much as you would think so.
Yeah.
Now, platelet-rich plasma actually is the one that has over 20 randomized clinical trials now showing that it's more efficient when it's used with a low leukocyte concentration when compared to HA, when compared to cortisone, ozone therapy, physical therapy, and so forth. So that's something that we actually use as much as we can based on the economical situation of the patient to try to keep them out of trouble for as long as possible. We never do this in isolation. We always do this with the gel because it seems to have a synergistic effect, as well as with physical therapy, because I don't think there's any value on doing these therapies on their own, and they should be always paired with physical therapy.
With regards to the PRP, it's interesting that you make mention of the fact that it's PRP with low leukocyte as well. From my knowledge, the reason behind why you say that is there's no standardized form for PRP treatment, right? There's no, if you do PRP, you're going to get this and this is it. It's not like a corticosteroid injection where they're going to give you X amount of ml and the X amount of ml is going to contain, that's it, the corticosteroid injection. With the PRP, that can vary greatly, right?
That is a great question. And this is something that we've been studying and trying to understand for a while. I had a question that somebody asked me, I was in a meeting, and somebody asked me, what is the right way of preparing PRP? So I was fairly embarrassed because I didn't know the answer. I said, I don't know, this is how we do it, but I don't know why. So I went back home and we prepared a study. It's called A Call for Standardization of Platelet-Rich Plasma. It's published on Journal of Bone and Joint Surgery. And we basically, looked at everybody that had published on PRP, 105 studies throughout the body in the orthopedic literature. Only 11% of the studies reporting on every single thing that you need to replicate in that study. So there's no external validity. We basically created a plot with how many RPMs and how much time they used to prepare the PRP, and there were no two dots that sat on top of each other, which means that there was no two studies that prepared this PRP the same way, which means that we have no idea how to prepare it, or if it even matters. Now that brought us to the second question: what is PRP? It's platelet-rich plasma. So some people defined it as an increase in platelets of more than 5 times the baseline. Some people said that it's more than 1 million platelets. So we said, okay, but why? So that's arbitrary, right? People just put that definition because they thought it was, a good definition, but there's no rhyme or reason as to why they chose that number.
Yeah, kind of like 10,000 steps is what you need to do in a day. There's no, it's just, it's stuck.
But why? Why? Somebody does 1,999 steps is bad, and if somebody does 10,001 is great. Right? So, that created another problem because there's a study done by Martha Murray here at the Brigham and in Boston and Harvard, where she basically was looking at ligamentization of ACL repairs, and she saw that when there were too many platelets, the ligament was actually not healing very well. So there's a ligamentization problem with that. And so we did a similar study where we did an animal study on rabbits on MCL healing, injecting them with PPP, so platelet poor plasma, PRP 2 times the baseline and 4 times the baseline. And what we found was that the histological characteristics of the ligament itself were actually worse when you had more platelets, as well as the biomechanical properties. So probably having too many platelets is good in vitro, but not so good in vivo. And that's something that we need to understand better. And maybe what we're looking for is not too much of the platelets, but mostly of the growth factors that we need. And those should be targeted to the tissue that we're treating. Let's say if we're treating cartilage, VEGF, which is the factor that will create more vessels, is not needed because that's going to create more fibrocartilage instead of cartilage. But that's great if you're trying to regenerate muscle. But you don't want TGF if you're trying to regenerate muscle because that's going to create more fibrosis. So those are the things that I think we still have not very clear, and that we need to be more specific and customized in order to treat these specific injuries with a very specific molecule, and not just a shotgun approach that we have been doing with PRP.
Yeah. Just spray that buckshot out, and each piece of buckshot's a different level of PRP. Interesting. Now, obviously, we've stayed quite focused there around about in a way on the knee. With things like PRP, it can also be used for lateral epicondylitis, medial epicondylitis, that sort of thing. Obviously, you're working in the MLB and the NBA as well. I assume you'd probably get that more so than in the soccer. Do you end up using biologics for the players for the upper extremity side of things as well, or do you guys steer away from it and tend to head more down the physio side of it, or if necessary, depending on what it is, a surgery? Or
the two best indications based on the evidence that we have available are the symptomatic treatment of osteoarthritis and the symptomatic treatment of lateral epicondylitis. There's one randomized clinical trial for gluteus medius teres from a really good doctor from Australia. There's a bunch some in the shoulder, some in the hip, but the best evidence is for lateral epicondylitis as well as for the knee arthritis, symptoms of knee arthritis. We still use it in hips, we still use it in shoulders, but we always are very upfront with that and say, the evidence is not quite there to support its widespread use, but it is, one of the, if you extrapolate the literature from the knee, you would expect that it would have a similar, effect on the shoulder as well as on the hip.
What about with regards to stem cell therapy? Have you guys ever looked at using that or looked at the research behind that and whether or not that's appropriate for any of the players or the general population that you treat? So
in the United States, we're not allowed to use proper stem cells. So cell-based therapy is when you basically remove one cell, that cell is able to create colonies, and then they have a bunch of characteristics such as they should be able to adhere to plastic, and they should express some surface markers positively and should not express some others. That's how you actually call something a stem cell. What you do then is you identify those, you put them on a petri dish, on an enriched medium, and make them grow. You wash them out again for the ones that are weaker, grow them again. So by the end of that, you have 40, 60 million cells. What we can do here that it's FDA approved is something called bone marrow aspirate concentrate, where you take bone marrow, you concentrate that, and you get 40, 50,000. So it's a major difference between a true cell-based or true stem cell therapy. We tend not to use that as much. There's a nice clinical trial, double-blind, from the Mayo Clinic in Florida, where they compared 25 people that had bilateral knee osteoarthritis, same degree. They did BMAC on one side and they did saline on the other side. The outcomes in regards to pain for those patients were pretty much the same. They looked at MRIs and they were same outcomes. So you're comparing $2,500 at the best case versus $0.2.
Yeah,
we did just exactly the same. So there's not enough evidence, at least as of now, to support its use, as far as I'm aware. And now the FDA has released another, update showing that, the stem cells derived from amnion are not allowed here in the States as well. So that's something that we need to consider, because there's no homologous use, right? Like that's one of the main things that they want to see. It's untouched, so you can't do more than just spin it. You can't put or take anything from them, and it needs to be used in an homologous way. So there's no way to say that we're going to use fetal tissues or placental tissues in any homologous way unless you're pregnant.
Right? Oh, geez.
So
Spoils the the chance there almost, eh? Okay. And then moving back towards surgery, if if we take a look at the knee with something like an ACL, I mentioned it before we started, there seems to be a growing body of research around spontaneous healing, at least in the physiotherapy community side. You're starting to see a small trend going towards not operating. From my side, the way that I've looked at it is it depends on the individual in terms of what activities they want to get back to and what level of activity they'd want to get back to as well. If they want to compete at a higher level, or if they're going to Sunday league football kind of thing, English football, soccer. And then the argument that you often hear back is there are people who compete, be it in the NBA, the MLS, English Premier League, that are also competing without ACLs, who haven't gone through the surgery. What's your take on that side of it? And where do you go with that?
I think it's a very complex decision. And the reason being is that it's complex for all the things that you just mentioned. What are the activities that they want to get back to? What would they be doing? How, all these external factors that you can actually modify. Let's say if somebody's used to doing triathlons or doing a lot of pivoting, they can say, well, I just want to bike now and swimming, he might be okay. But those are the factors that they can change. There's some intrinsic factors that they can't change. So the slope of a tibia, concomitant injuries such as having a posterior root tear of lateral meniscus, those things will make the knee even more unstable. So we've seen from the Norwegian registry, from the Danish registry, the Italian hospital in Argentina has published intrinsic healing of the ACL, people that can cope with an ACL injury even though it may not heal. That all depends on all these factors that we just talked about, how much instability that knee has. And it's not only related to the ACL itself, but also the concomitant injuries, as well as the activities that they perform. So I usually tell patients, you're not going to die about this. Your ACL will not kill you ever. This might heal, this might not heal. Even if it doesn't heal, you might still be okay. There are copers and non-copers for this type of injury. And we just don't know who you are and what where you're going to be. If we start seeing more concomitant injuries on the MRI, that tells me probably most likely than not, those people will not be able to cope with it. If you have a bigger slope and if you have a posterior lateral meniscus root tear, those patients would be significantly unstable. And that's why, the problem with the ACL is not the anterior posterior translation of the tibia, is the rotational component. The brain can feel up to 1.4 degrees of rotation. So anytime they try to pivot, they're gonna feel that, and they're not gonna like it. Now that can bring other issues down the line, which is further arthritis, because cartilage is very good at resisting load, but it's not very good at resisting shear forces. So as soon as you have that rotational component in there, that might not be a great thing for the longevity of the knee. But again, there's people that can cope with it just fine, or they can modify their activities to cope with it. And that's something that goes into the decision making. I have some 40, 50-year-old people that come and say, I was biking, somebody almost hit me with a car, I just planted my leg, hurt an ACL. What do you do for activities? Well, I just ride my Peloton and, I go to work walking sometimes, and, I just like to run straight. And I'm like, well, most likely than not, you're not going to have an issue with this. If you go skiing once a year, you might just use an ACL brace and it'll be fine. Now, if they say, well, I want to play recreational soccer, or I want to play basketball, well, I want to play tennis, those are the people that I say, well, you probably, might need this in the future, but you can try it out.
Okay. I think one of the things that you mentioned is it's complex because of a multitude of factors. And one of the things that you mentioned earlier is that you often have your patients going for sort of prehab, and then the element afterwards of rehabilitation can be so important. Now, I've seen people, and I've mentioned this before on the podcast, who were post-op ACL and were 6 months down the line, and what was, in my opinion, rehab that didn't follow too much structure, as they were running, yet they can't do a body weight squat. So when they then came to our clinic because they'd moved house, not because there was any, they were uncertain in their provider, we sort of took them right the way back down and said, listen, we're going to work on these things first. We need you to be stable and steady in what you're doing on one leg first before we're going to start doing these explosive things like running, jumping, and getting you back to sport. It's a bit of a blow for the patient, but from our side, what we saw with the patient and what we've seen over time is that's keys to success in rehabilitation. Obviously, everyone that you operate is someone that you want the best for. And part of that is ensuring that they have the best rehab that they can have. Obviously, with your professional athletes, those guys are going to go to their team physiotherapists. They're going to have, the cream of the crop there. When it comes to the wider populace, what is it that you look for when making referrals to physiotherapists or when making professional relationships with the wider community? What are you looking for from your physiotherapist? So for people like myself,
that is a great question, and it's extremely important to me. My portion of success in an ACL reconstruction is minimal, to be honest. I do the same over and over. It's probably 10-15%. And I had a chairman in Argentina that used to tell all of us, if I show a chimpanzee how to do surgery over and over again, he'll be able to do it. What we do is not that difficult. You just need to learn how to do it and put it in the same place and just be methodic about it. Right. And even though we do the same exact surgery with the same implant, the same graft, outcomes can be widely different. And the reason being is that a good physical therapist can make a whole world of a difference. And I can tell that right away. The first email that I get from them saying, what they're at, what they're doing, what the range of motion is, how detailed the email is. He had a meniscus repair, so we're not putting weight on him. Can we do this or that? I can institute BFR. I can do, when I see those physical therapists that are completely engaged in the treatment, that gives me peace of mind that those people will go really well. Now, when I see an email where they send me just the name of a patient without the last name, date of birth, they're telling me, you just did an ACL repair when it's a reconstruction, like all those like errors and not specifics, that tells me that might be a problem. Now, there's 50-50. The physical therapist has to be really good at treating sports people, because it's not the same to have somebody that knows how to treat an ACL than having somebody that knows how to treat a knee replacement. It's completely different. And if you are used to treating knee replacements, you'll probably not do a great job at treating an ACL reconstruction. But it's also 50% from the patient, because I truly think that physical therapy is very important, but the home-based exercises that they're supposed to do is just as important. If they're not compliant at home, then whatever you do in clinic 2 hours a week, it's not going to be enough, or 3 hours a week. It needs to come 50-50. But I think even then, the physical therapist plays a major role, because educating the patient is another big part of therapy and another big part of success, and making them understand, you come here for 2 hours to 3 hours a week. That is not enough to rehab a knee. You need to be compliant at home. You need to be doing the exercise at home. This is the program that I want you to do before I see you back again on Thursday. You need to be here. This is our goal. This is our, small goals that we need to accomplish in order to get to a good outcome. I really enjoy communication with PTs. I learn a lot from you guys. And, I have some partnerships that I've created with some physical therapists that has been extremely good, because I know where to send those patients. And even sometimes they're not in my hospital, I know where to send them to when they're having issues, or if I have to recommend somebody that is good, I just send them to them, because I know that we can communicate well. In the event that they're my second eyes as well, because if for 4 weeks we didn't regain full extension, they know that they have to send them back to me, because we need to get them a metal dose back or lysis of adhesions, mobilization under anesthesia. We need to act as a team. And if that relationship is broken, then it's not going to work for anybody, mostly when things don't go the way that we want to.
No, absolutely. And I think it's also important what you've highlighted there of, there's a big aspect that comes from the physiotherapist's side of it, in not just the rehabilitation that they put the person through, their experience with what they're rehabilitating as well, and then also their communication side of it, but then the patient aspect too. from my side as a physiotherapist, maybe if there are patients listening to this, it's really easy to see the patients that aren't doing their rehab. Now, that's not to say that if a rehabilitation is not going the way that we want, if a rehabilitation is delayed, that's entirely down to the patient. Sometimes it can also be the healing process for that individual person. Everyone's different. I've done easily a good few hundred meniscus rehabs for patients, and yet with my own, I had a delayed recovery doing my exercises. But yeah, sometimes it can happen. But when the patient comes back in and they're complaining of the pain and they're walking in worse than when they left the clinic the last time, and when you ask them to show you the exercises that they should have been doing and they can't remember it, they wouldn't remember it if you put a gun to their head kind of situation, it's very clear to see that in this partnership between myself and the patient, that they've not held up their end of the bargain. When you see situations where things aren't going to plan, things aren't following the normal pathway, shall we say, at what point do you intervene? And then I suppose it maybe even a question one step prior to that is, how often do you see people post-op? I think it's probably different if it's a total knee than if it's an ACL. It comes in two parts then. How often will you see someone post-op? And then at what point, if you see things going wrong, at what point do you ring the bell or pull them out?
So I see them usually, 48 to 72 hours. I want to make sure that they know that they can move their knees. And, an ACL, a lot of people think the knee is going to explode if they move it. And, I make sure that I see them either the next day or the day after, just to make them move. And I say, you have to be at 90 today so that we can, get you going. If you're 0 to 90 today, we're going to be fine for the rest of the recovery. Anything will be easy. I emphasize extension quite a lot because that's the only thing that we can get back. So I say, do never put a pillow below your knee, just always underneath the heel. Do your quad sets, your prone hangs. Those will pay off its dividends pretty quickly for us if you do so. I make them, bend their knees to 90 degrees. If they have a massive effusion, I drain it so that they can move their knees. So I intervene very early on because I want them to go as smooth as possible. Then I see them at 2 weeks to remove the sutures, 6 weeks, 3 months, 4 months and a half, 6 months, 9 months.
Wow.
How fast do I intervene? As fast as possible. As soon as I see that something is deviating from normal, I get them a mental dose back. I send them 5 times a week to physical therapy. I get that motion back early on. And then, I want to solve it right away. It's a really bad idea to wait for extension, for example, or flexion after 3 months, because you lost that golden window where you can actually intervene and get some results. After 3-4 months, it's very difficult to get back.
Absolutely. I think there's not one delayed rehabilitation that I've seen where they had extension at the start or they had extension very quickly. It's always with people wwho don't get their extension that you can almost guarantee that this is going to go a little bit slower. Like yourself, like you mentioned there, it's always a case of we want that extension first. I don't care about much else of anything else. I need you to get that extension. And at least from my side of it, also the factor of if you don't have it back within those first 2 weeks, then it's really difficult to get and it slows things down. But also the thing that these people are going to be doing the most, because they're so limited, is walking around the house. And if they're walking around the house in that flex knee position, they're only going to emphasize it and they're only going to make it worse every time they make that step. And to anyone listening, I don't mean to scare you or to give you the impression that if your knee is flexed, you're gonna blow it up and it's gonna fall off the next day. Not at all. The emphasis on getting that extension back is paramount to a good, solid rehab, and that might not come in the first day. What I did pick up on there that was really interesting for myself, and maybe you saw my eyebrows peek up there for a moment, was you mentioned that if you notice a lot of effusion and you see them 2 to 3 days after surgery, you're going to drain it. Now, that's not something that I've seen here in the Netherlands, and it's also not something that I saw in the UK. And I did a brief stint over in the US, in New York, as an intern, and I also didn't see it there. For me, the reason that's really interesting is one of the reasons that they don't tend to do fusions here or fusion training so often is that there's no guarantee that it's not going to swell back up. What's your reason in there? I suppose not your reason. What's the justification behind that side of it? Because yeah, there are many times where I see it where it doesn't follow that pathway. And if it is drained, maybe within 2 days, it's back to where it was.
That is a possibility and gets discussed with the patient. Extension or the dilation of a capsule causes a lot of pain, and drilling of the tunnels causes a lot of bleeding. So if you see a patient that has a massive effusion at 48 hours, that patient will not move for the next 2 to 3 weeks. And that is a big issue. And as I told you before, I really emphasized motion early on. And that effusion is a main driver for not being able to move. So at least flexion is not going to come if you have a full knee. So I drained them. I have not had an issue where I had to drain them again. Usually it bleeds a little bit more, but not as much as the first day, because that's where the bone was, just reamed, and it's going to bleed the most. Now you have another graft, you have a screw in there. So it's not as prone to bleeding as it was right after surgery. After that, we do a compressive taping. So we do, an ACE wrapping, make sure that is very well compressed, and a lot of icing. It will swell up a little bit more, but it's not going to go back to where it was before. And we have been extremely successful with that approach for patients that had an extreme amount of pain and really bad range of motion in 48 hours. After I drain them, I can get them to bend to 90 degrees right away.
Wow, that's awesome. It's I don't know how much work you do with wrestlers or mixed martial artists or even rugby players, but that's almost the same approach you take with a cauliflower ear. Once it swells up, to drain the ear and then apply that compression. You get a bandage or whatever, wrap it around the ear, wrap it around the head, make sure it's really tight to make sure that doesn't swell back up. It's for me, that's really, really cool to hear, and maybe something I can discuss with a surgeon if I see an instance where perhaps that could be worthwhile, could be a nice approach to do. And you say there that you've also had really good outcomes with that as well.
Yeah, I think that if you have to put two things in the decision making. One is, what are the benefits and risks from each thing that you do? The risk is infection, of course. The benefit is motion. If I think that a patient might end up with a lack of extension or something like that, potentially form a cyclops lesion and so forth, then that to me is a catastrophic outcome as well, because that means the patient will not be happy. These are young patients that we're operating on, and having 2-3 degrees of lack of extension can change or alter their gaits, their biomechanics, their backs, their hips. So for me, it's a big deal. I really think that once you get range of motion, then the rest can come whenever. Strength can come whenever, and it doesn't matter. But if you lost that 6 to 12 weeks of that golden window early on after surgery, you're pretty much lost. Not too much you can do after that.
It becomes a really, it's an uphill battle, trying to roll a boulder back up a hill kind of thing. You mentioned there one of the downsides could potentially be infection. Now, I know I'm jumping about a fair bit here. Where do you stand on removing pins and plates for, let's say, lower limb fractures? I've had a fair few patients that have complaints following with repeated swelling, perhaps, or limited range of motion where they feel a physical block in the joint. And one of the things that the surgeons will often say, understandably, is that there's a higher risk of infection by removing the plate and the screws, and you may end up worse off. Where do you stand on something like that, depending on, I'll ask your opinion on it first, and then I'll give my 2 cents on it.
So it depends on if it's causing symptoms or not. If it's just for the sole reason of I'm able to touch this hardware, but it's not causing me any pain, I say it's a terrible idea to remove them. Because a hardware removal can be a 5-minute surgery or a 4-hour surgery where you end up pretty much destroying the bone around it to take it out. You don't know if you're not the surgeon that put it in, how those screws look like, if they have been, the anchors are not working anymore. So it's not a great thing to do if you're not having symptoms. Now, if you have hardware irritation, then I think it's a very reasonable thing to do, because you're solving symptoms that are caused by the hardware being there. Now, infection is a risk like with any other surgery. I don't think that it has any other, infection risk just by removing hardware, to be honest, just like it did for, your first or index procedure, to be honest.
Again, it comes back to what you said earlier. If it's down to the individual, it's not a hard and fast rule. It's if for them there's symptoms, if for them there's issues. Have you seen many issues surrounding hardware in terms of repeated swelling despite good rehab outcomes? And I suppose if I get more specific there, for a patient who has had a good rehab outcome and then they're finished with their rehab, they've done their sport, and then let's say 6 months down the line, they decide, I'm going to put the sport down for a while, not for any other reason than work's busy, school's busy. All of a sudden, a month, 2 months goes by and they haven't done anything. And then they're going to have swelling, they're going to have limited range of motion or something like that. In that situation, would you then consider looking at the hardware side of things again? Or would you review that with the patient?
I would review the patient. And I think, again, what we discussed early on comes back again over and over. It's a joint decision. So my job is to inform the patient all the benefits, the risks from each approach. And sometimes not doing anything has some risks as well, right? If you leave a hardware that you know it's moving, it might be even riskier. So it's important for them to know exactly what's going on, for them to know also that this is not going to be a life-threatening event, and that there's some risks and benefits from each approach, and that sometimes removing the hardware just for the sole purpose of removing it might cause you more issues and prolong the recovery. But sometimes that might be the end of the story for you, because for example, I had a patient that had two screws that were pretty much sticking out from the skin that didn't allow him to kneel. It was causing a lot of irritation. Removed those two screws, and the patient was like completely satisfied with it. So, sometimes it can be a life-changing event that it's very simple to manage.
Absolutely, yeah. And then pulling it back to something that you mentioned earlier when you were talking about rehabilitation, when you were talking about the different things that people can do. I know I think it was last year, were involved on a paper researching this, but what's your take as an orthopedic if your patients are doing BFR or not? Have you seen many benefits or uses out of it? Or
So the answer is, as of now, I don't know. We've done a systematic review which has shown that it's beneficial in multiple ways, from the strength, the muscle volume, and so forth, recovery. It's been very good in regards to the literature, although there's not a lot of randomized clinical trials. We're starting now 2 randomized clinical trials, one for FAI, one for ACLs on BFR. So I'll be able to give you some good insight, Sonny, as soon as I have those completed, but it's going to be probably 2-3 years from
perfect.
now.
I'll still be here if you're willing to come back on, that's for sure.
We can do a 5-minute podcast to just review the outcomes.
Sounds perfect to me. Fantastic. If we stick to the elite side of things now, I think it's changed a lot now, maybe in the last decade or so. But it used to be a case of if a player has surgery for something like an ACL, for example, when they came back, they weren't the same person that they were before they'd left at whatever point in the season. What do you think it is that's changed? Someone that's been in the game for quite some time, what do you think it is that's changed, be it in the management, be it in the surgery, be it in the techniques or what have you? What's been the biggest outcomes in your opinion, or the biggest game changers in your opinion, rather?
So the question is basically, everybody wants the player to be at the same level that it was before the surgery. And I think that can be achieved. There's some deconditioning that happens after surgery. For our professional athletes, it's kind of easier to do because they have, they get paid millions to go back to play, which helps the brain a lot. The second thing is they have, the top of the top physical therapists, ATCs, machineries, and everything to complete that rehab. And they're naturally skilled. That's why they got to where they were. So it's easier for those folks to go back to a previous level of activity. That being said, there's a psychological component. We look at what are the reasons for not returning back to the same level. There's usually a psychological component to that, fear of re-injury, fear of that, problem that happened before, changes in the mindset of that player, or, there's a whole bunch of things that are not, critically or specifically from a physical standpoint, but mostly from a mental standpoint that we also need to be cognizant of, because that can aid into a different or a suboptimal outcome in the return of sports of that patient. Now, we looked at multiple NFL, players that have undergone ACL injury, meniscal injury, and even if you remove a little bit of a meniscus, although they're able to go back to sports successfully, return to sport is such a bad definition, because return to sport shouldn't be only being able to return to a game, right? How many minutes did they play? How many games did they started? How many passes did they completed? How many goals did they scored? How many minutes did they played each game? All those things should be compounded. So it's not just return to the game, but performance is the word that we should be, assessing. Can they go back to the same performance that they had before the surgery? And it's humbling to see that sometimes we're not as good as we think we are, just by looking at return to sports.
Very interesting. I think that's also a really heavy distinction to make, actually, in terms of return to play or return to performance, because there's also a lot of people that when they return to play, they return to play at levels much lower than where they were. It's interesting that you bring up that psychological aspect. Actually, it was something that I wanted to ask you about. How many or what other professions are you working with, as physiotherapy is just one aspect of it? For us, the orthopedic side is just one aspect of it. Depending on the patient, there may be multiple different things that they need. So what other professionals are you going to be working with to ensure the best possible outcome for your patient?
Well, athletic trainers here in the United States are a big, part of the recovery, as well as, sports psychologists. So I was telling you before, the mental portion of things is usually underestimated and underlooked. And, in a big number of patients, that will be the main driver for returning or not returning back to the sport. So I think it's something that needs to be looked at in a constant basis, just to ensure that not only the physical portion of things will be, sound at the time of return to sport, but also mentally those players will be in good shape.
I've seen it also not just in athletes, but one of the things that will stick with me, I think, for my whole career was an older gentleman when I was in the States on placement, actually, who he'd had an accident when he was doing some work around the house, fell off of a ladder. He had a really bad concussion, really bad bruising. He broke his wrist, and he also had hip complaints following as well. Unbeknownst to all of the staff, he'd developed a massive fear of falling, of just, if he falls again, he's never going to be able to get back up. One day at the clinic, he'd went to sit down on a chair, but grabbed one of the roll stools. It's one of the things that whatever healthcare profession that you're in, your supervisor will tell you when you're first doing your placements, don't let a patient sit on that, because there's every chance that it will roll out from under him. And the chair rolled out from under him. He fell. It was the biggest thud, and the clinic just went quiet. Everyone turned and looked at the old lad. He started bawling his eyes out. Now, in the back of my mind, I thought to myself, damn, that's placement over. I'm going to be sent home. He's hurt again. Maybe he's broken his wrist again. Maybe something else has happened. This is fantastic. I went over, helped him up, and sat him back down. And once he'd cleared the tears, what he said was, you have no idea how much falling over just now meant to me, because I feel fine and I feel great. And, he started crying again. And I was like, so confused, had no idea what the hell was going on there. And he was like, I've been so scared of falling in case something happened and I couldn't take it anymore. This falling over right now has shown me, essentially, I'm massively paraphrasing here, but has shown me that I'm able to fall over. And that just means so much to me. And, it helped the rest of his rehab by falling over. And I think that goes into what you were talking about there, of the psychological aspect for a player who, if they got injured going into a tackle, will from that day forward be hesitant to go into a tackle. And yeah, the psychological aspect is just so important and so undervalued. And I think as physiotherapists and as an orthopedic surgeon, I think it's really important that we pick up on that during a patient's rehabilitation, that we can guide them and get them through that door early enough. Like you mentioned, when a rehab might potentially be going bad, you want to pick that up straight away rather than let that fester. What would you say would be the three biggest tips from yourself when working in this field, when working with athletes or working with the Gen Pop, for someone to look out for, be they a surgeon or be they a physio or what have you, to ensure the best possible outcomes?
So first of all, communication. 1,
2, and 3.
I would say that's 1, 2, and 3. The fourth thing is just be humble and accept that sometimes, there's things that escape your expertise. So for those things, rely on your partners. For us, you guys are our partners, and being able to rely and say, what do you think? What have you seen? You just give them a call. But it's all related to that. I think, the fact that sometimes we send somebody to physical therapy and we don't take 2 minutes to talk to the physical therapist, it's just something that I still don't understand. Like, if you want a physical therapist to give the best treatment to your patient, they need to understand, they need to buy into what you're trying to do, what you're trying to accomplish. And if they have no idea of what you've done, there's no way they will be able to help you. In the same way, if the physical therapist sees something that might not seem good or might not seem the way, correct, then reaching out to the surgeon and say, hey man, there's something that is not right. This is what I've seen, we've been achieving this, but all of a sudden we've had this regression, and I think we should do this, this, and that. I think that communication can save a lot of time for patients, doctors, and physical therapists, just because, it makes everything better. It keeps the ball rolling and achieves the best outcome for patients.
Awesome. Any last little bits that you'd like to leave the listeners with?
Well, I think I hope that this partnership between surgeons and physical therapists, as you said early on today, continues to grow, because as we all know, and we are starting to understand more and more how critical this partnership is in the success of patients. Sometimes we concentrate too much on where we put our femoral tunnel. If it's at 10:30, 11:30 o'clock, it doesn't matter, to be honest. People used to do transtibial ACLs, put the ACLs on the roof, and patients did well. And as long as you have a good rehabilitation, you are supported not only physically, but mentally, that's going to achieve the best outcome. So paying attention to the details, to specific details in surgery is important, but it's more important to pay attention to the extra surgical stuff, which means, talking to our physical therapist, ensuring that the patient is well, not only from a physical, but also from a mental standpoint. Act early. If you see something that is deviating from what you're used to seeing or from what is normal, don't let that go for 3, 6, 9 months. Act as early as possible so you can get that patient back as soon as possible.
Perfect. And where can people find you on social media if they wanted to find out a little bit more about yourself or what you're doing, what you're up to?
So social media is a big component of my practice as well. Chicago Sports Doc, it's my Instagram, Facebook, and Twitter. And, I have a website called jorgechallamd.com that everybody's welcome to visit. I have all my physical therapy protocols over there for all knee, hip, and shoulder related surgeries. And I'm always happy to take emails or calls from anybody around the world that has a comment or a consult that I can help with.
Fantastic. And to anyone listening, I would definitely recommend checking out Jorge Chahla's Instagram, as there are some really gnarly videos of the surgeries and stuff in it. Yeah, especially if you're a physio, if you're interested and you're working in orthopedics and you're yet to see one live, it is absolutely phenomenal to see the level of detail and the surgeries going on, which is just awesome to see. Thank you very much. Really appreciate your time, and enjoy the rest of your day.
Thank you very much, guys. Truly appreciate it.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this. We appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.